of lower motor neuronal control of movement by considering the clinical picture of individuals that have suffered damage to their lower motor neurons, to their spinal nerves, or to the circuits that govern the output of those lower motor neurons. This is called the lower motor neuron syndrome. So my learning objective for you is simply to characterize the signs associated with damage to lower motor neurons. So this lower motor neuron syndrome has several components to it that I want you to be able to recognize. If we section the nerve that supplies the skeletal muscle, or if we injure the ventral horn of the spinal cord where the cell bodies of those neurons reside, we will see a response in the muscle tissue. Over time, that muscle will atrophy. But along the way, we might see abnormal contractions of individual muscle fibers and of individual muscle units. And these abnormal contractions we call fibrillations and fasciculations. So a fibrillation refers to the contraction of an individual muscle fiber. A fasciculation would be the contraction of the muscle fibers of a motor unit. And this is a pathological sign. It indicates the disruption of normal signaling that comes from the spinal cord to those muscle fibers. In addition to these changes that reflect the disrupted physiology to the muscle fiber, there are changes that are more directly indicative of damage to the lower motor neuron itself, or the axon that allows that lower motor neuron to communicate to that muscle fiber. And these kinds of signs and symptoms are reflective of the loss of the control of voluntary movement. So there can be muscle paralysis, implying a nearly complete loss of volitional control. Or if the loss of control is less than complete, there still may be profound weakness, and we call this paresis. So the idea is that our brain is sending signals to the spinal cord commanding a voluntary movement like a contraction, and there's profound weakness there. Not because the signal is not being received by the spinal cord necessarily, but rather the output from the spinal cord, or perhaps from the cranial motor nuclei, to the muscle fiber itself is the problem. Now, going hand in hand with this loss of volitional control or this profound weakness would be a loss of our myotatic reflexes. So this is what we call areflexia. So there may be a sensory arc that's intact, but without the output from the alpha motor neuron to the muscle fiber, there can be no reflex. And with the loss of volitional control, with the loss of the reflex, we would expect there to be a profound reduction in muscle tone. So this is a devastating condition that is very characteristically observed clinically. So one can expect to see changes in the muscle fiber. One can expect to see evidence of a dysfunction in the reflex arc that supports muscle tone and the execution of voluntary movement. And you should, as you advance in your clinical studies, come to recognize this lower motor neuron syndrome and differentiate it from other kinds of movement disorders. One important differentiation that we'll be making in a set of tutorials that will be forthcoming will be a distinction between the lower motor neuron syndrome and the upper motor neuron syndrome. What you'll discover is that in the hours to days after damage to upper motor neurons, the patient might look very much like a person who has suffered a lower motor neuron injury. But over time, a different set of signs and symptoms will evolve, and that evolution will be a key feature to focus in on. So in addition to thinking about the anatomy that's been injured, you should also recognize the time course of the development of that injury. Even for the lower motor neuron sign, for example, it will take some time for muscle atrophy to set in. You won't see that right away. Likewise, the fibrillations and fasciculations tend to be indicative of the early phases of injury. Over time, those will subside as the muscle fibers become atrophic. So paying attention to the time course of the development of these signs and symptoms and how they may change is going to be a key aspect of your clinical observation. Well, this concludes our discussion of lower motor neurons. The next time we come together, I trust we will be talking about the means by which upper motor neurons govern the activities of our alpha motor neurons and the local circuit neurons that coordinate their output. So next time, we'll be talking about upper motor neuronal control of movement. I'll see you then.